So we talked about the rationale of, using Clostridium novyi and Pembrolizumab. So Clostridium novyi, this is an attenuated bacteria, anaerobic bacteria with a non-toxic component to it that, really has an affinity for the hypoxic areas in your tumor environment and to be able to lyse and cause apoptosis and cell death. So the idea of synergizing C. novi with an immunotherapy agent such as Pembrolizumab, which is an immune checkpoint inhibitor, has not been tested previously, especially with the bacterial vector. We have a lot of evidence in the oncolytic viral space where we know that there's a lot of synergy between oncolytic viruses and immune checkpoint inhibitors. We saw that preclinically, and also we see that with clinical data that we've seen so far with TVEC in the past in melanomas. So this study was really trying to understand the first of its kind as a bacterial vector. What is the synergy between the potential efficacy of Clostridium novyi with Pembrolizumab together? So far, at our data cutoff at October 2022, we had enrolled 16 patients so far at the MD Anderson Cancer Center, and these patients varied in histology. But what we've noticed is that patients, especially with nasopharyngeal carcinoma, undifferentiated type, and also HPV-positive squamous cell carcinoma of base of tongue, vulvar melanomas, and mucosal melanomas especially, and chordomas, these are the four histologies that really shown profound impact in terms of response rate and durability of the responses as well. The schedule for this trial, the way we designed it was to give on day 1 the Pembrolizumab to kind of really prime up the T-cell immune system, and then on day 8 to deliver the Clostridium novyi percutaneously to accessible lesions. We avoided any lesions that were deep or in the visceral or in the peritoneal or thoracic cavities, especially because this is a bacteria that can germinate and then eventually cause lysis. And for safety reasons, we only chose accessible superficial lesions that were either manually palpable or radiologically, accessible. And what we did was, and then the Pembrolizumab was given every 3 weeks, and this continued on for 2 years or less, as long as the patient-derived response. Our best responses were actually in nasopharyngeal carcinoma, where our best patient had a -88% response rate, and with a durable response for almost 2 years. And one of our mucosal melanoma patients actually had a complete response for almost 2 years. We also saw that the duration of response of all patients on this trial was around 8.8 months. And also many of our translational data that we have from the pre and the post-treatment biopsies and the PBMCs, where we were able to show actually uptake in the cytokines released by the T-cell activation for persistently happening all the way to day 366. That's more than a year. And that kind of keyed us into the fact that, we only gave 1 dose of C. novi, but with the continuous every 3-week infusion of Pembrolizumab, we were able to expand that durable response in these patients translationally as well, which speaks to the synergy between both. In terms of safety and tolerability, only grade 1 or grade 2 events were noted. Most of them were injection site reactions. Because this is a bacterial vector, we saw a lot of germination. We're talking about ulcerations or injection site pain, which was controlled with oral doxycycline. And these patients were monitored in the hospital for that first week when they received the treatment as well. This trial is still recruiting patients, so the recommended phase 2 dose is still pending, but we have tested this in 4 cohorts, and we hope to enroll and complete our trial recruitment very shortly and report the results. Yes.